So just to start, if someone is diagnosed with a rare neuroimmune disorder, does this mean that they are immunocompromised or more susceptible to infection? Or what does that mean in terms of their kind of immune system? And does that differ based on the rare neuroimmune diagnosis?
It's a very important question. There is a lot of variability in the term immunocompromised and a lot of variability in the meaning of that situation in patients with rare neuroimmunological disorders. For example, there are patients in which diagnosis of monophasic myelitis, meaning that patients that had experienced only one episode of myelitis in life, and after that they never experienced any episode or any flare-up of myelitis again, or the myelitis basically remains just as a one-time episode for life. Those patients have tendency to have a better immune system as compared with other patients that have tendency to have a relapsing and remitting pattern. For example, patients with neuromyelitis optica, in which there is a pattern of recurrence of flare-ups, those patients may be more susceptible to other challenge to the immune system, like infections by coronaviruses. Patients that have other autoimmune disorders, let's say an MDA or the encephalitis associated with NMDA, those patients, again, may have some susceptibility based on the fact that there was some sort of disarrangement of the immune system, and there is more damage of structures in the brain that may expose them to be more susceptible to secondary symptoms or problems that are present in coronavirus infection. So those patients, for example, if they experience fever or they experience a decrease in oxygen content in the blood, may have secondary effects from the infection. So the summary is rare neuroimmunological disorders are frequently associated with some disarrangement of the immune system response. And the susceptibility is not necessarily defined because the presence of that rare neuroimmunological disorder is defined by the magnitude of disarrangement that that patient may have in their immune system, and particularly if they are exposed to immunosuppressive regimens or immunosuppressive treatments.
Okay, great, thank you. So if someone was diagnosed with transverse myelitis 7 years ago and was told that they have a low immune system, is that necessarily something that happens with transverse myelitis? Is this usually just kind of a one-time thing where the immune system, misfunctions and then things get better, or is this an indication of kind of a problematic immune system? And how can someone tell that might be the case or not?
Yeah, and just I'm coming back to my statement from the last question and answer. Patients that had experienced only one episode of myelitis in life. At this moment, if that happened, for example, 7 years ago or 10 years ago, I don't believe that those patients are going to be at high risk, particularly because if there is no pattern of recurrence or flare-ups, that means that the immune system at this moment may be stable and may be in good conditions. The problem is, what was the reason those patients presented with myelitis several years ago? And again, myelitis show up and is associated with different factors. There are patients that have monophasic or one-time myelitis because they were exposed some time ago with one virus that produced post-infectious reaction in the spinal cord, and subsequently there was a myelitis. Those patients unlikely are going to be at higher risk at this moment, even if the trigger for the myelitis was a viral infections in the past. What we know about this virus is eventually going to infect a large population in the world. And the immune system is going to react with a lot of variations. There are patients that are going to react strongly and will be able to control the viral transcription, the viral proliferation and replication, and eventually are going to have a more successful control of the infection. There are other patients, unfortunately, in which the immune system is unable to produce enough immunity to protect against the replication of the virus, and the virus may spread and produce more damage in different organs like lungs and the heart, and produce more problems. So summary of the answer is having only one-time episode of myelitis in previous years is not necessarily going to enhance the possibility that the coronavirus is going to produce a more aggressive or less aggressive disease. Eventually, patients will be in contact with the virus, and the immune system will decide what will be the magnitude of response against that virus.
Okay, thank you. And then is everyone with an autoimmune disorder at greater risk of a severe case or death than those without an autoimmune disorder? Or how might that, affect?
So the autoimmune disorder per se is unfortunately a risk factor for further complications associated with an infection by a virus. And that doesn't happen only and exclusively with coronaviruses. That happen also with flu. If patients with autoimmune disorder get infected with flu, actually the consequence is also going to be not necessarily a very good consequence. That's the reason we always advise patients with autoimmune disorder to get vaccinated for flu, because we like to avoid as much as we can contamination and infection by flu. So autoimmune disorder per se increase the risk of severity of coronavirus infections. Unfortunately, many of the patients with autoimmune disorders are also exposed to immunosuppressive regimens, let's say medications that decrease the likelihood for further autoimmune attacks. Unfortunately, those medications also will decrease the immune system reactivity against viral infections. So that is one of the reasons we are emphasizing to patients that they need to practice extreme precautions if they are with autoimmune disorders, with rare neuroimmunological disorders, and they are simultaneously receiving immunosuppressive regimens. And the reason is because the immune system at this moment in those patients is unable to produce a very efficient neutralizing response to minimize the infectivity by coronaviruses. So that is one of the reasons we emphasize extreme caution and the patients to take extreme precautions to avoid contamination.
So does that mean that someone with these diagnoses puts them in kind of the high risk category? And if so, what does that mean?
Yes, so there is a high risk for infection, and the severity of the disease may be higher because the immune system will be unable to have a very good neutralizing reaction against the viral infection. And subsequently, the involvement of organs like lungs and blood vessels and heart, for example, may be more severe, and subsequently, the severity of the disease may be higher. It's difficult to predict at this moment which patient populations, which autoimmune disorders, or which immunosuppressive treatments are going to be exposing the patients to a higher risk. We have, for example, some concerns that one of the reactions that the virus may produce in patients is aggressive immunological reactions that are called cytokine storms, in which immune mediators or chemical mediators from the immune system that are called cytokines that facilitate inflammatory reactions are going to basically be over-enhanced in patients with coronavirus infections and damage lungs and damage other organs of the body. Interestingly, some of the clinical trials that are being used at this moment for coronavirus involve some of those medications that we have been using for controlling the immune system. For example, there are some rheumatological medications, some medications that have been used in rheumatological disorders that have some degree of immunodepression or immunosuppression, actually are being used in patients with severe immunological reactions associated with coronaviruses. That doesn't mean that everybody who is taking immunosuppressive medication may have somewhat protection. That means that, unfortunately, in a subset of patients, the immunosuppressive treatment is going to be bad because we'll open the door to the infection, but we don't know exactly what is going to be the consequence of that.
Okay. And then, if someone becomes infected with this coronavirus, could this trigger a relapse? And does this risk differ based on the disorder? So whether they have a monophasic disorder or a more relapsing disorder? And just kind of for a real world example of this, one patient, their physician told them that their attack of optic neuritis could have been caused by a respiratory infection, and their body, attacked themselves in air. Could getting sick with one of these, including this virus, cause another attack to occur?
I don't believe that there is a right answer to that question, and I don't believe the right answer is we don't know. And there are many efforts going on right now by different groups in the United States and the world to have a better understanding of the answer for that question. And there are already registries that are being in place for tracking down patients with rare neuroimmunological disorders, myelitis, neuromyelitis optica, other disorders like multiple sclerosis, neurosarcoidosis. We like to understand that situation, if getting infected with a virus is going to modify the natural history of the disease, or is going to increase the amount of relapses or flare-ups. The answer is we don't know. And until we don't have a very objective description and follow-up of patients with rare neuroimmunological disorders, we are not able to know that answer. But I like to come back to a basic principle that we already know from many years of experience. Any type of infection, regardless if it's coronavirus, flu, or a regular cold, may produce exacerbation of neurological symptoms in patients with preceding neuroimmune disorders. In other words, if a patient with myelitis that happened 3 or 4 years ago experienced coronavirus infections, some of the symptoms associated with that myelitis or residual myelitis or residual symptoms, some of those symptoms actually may get worse transitorily. And that is not because specifically coronavirus infection, is that because the infection that they are experiencing at that moment. And if you remember, when you come to our visits in clinics, we always emphasize, pay attention to infections, because infections are frequently a major triggering factor for what we call false flare-ups of the disease, or pseudo-flares. And we are going to see this with coronavirus infection, that patient with previous history of optic neuritis, if they get coronavirus, transitorily they are going to have worsening of visual blurriness, or if the patient had a previous episode of myelitis, very likely patients are going to experience transitory worsening of sensory problems, or bladder dysfunction problems, or motor dysfunction. Is that meaning that patients are basically getting worse by coronavirus, or coronavirus is basically triggering another flare-up? Not necessarily. It means that the immune challenge produced by the infection is triggering and reactivating those areas that were symptomatic before, like in the spinal cord or in the optic nerve.
Okay, thank you. And do you think that we'll see, I mean, I guess we don't necessarily know yet, but see new cases of rare neuroimmune disorders being triggered by this virus, like we see with potentially other viruses? Or is
so
there...
this is a very nice question. Thank you for asking that. So one thing that we know based on the experience observed in China, in Italy, in Europe, and right now in the United States is coronavirus. This novel coronavirus is not a neurotropic virus or neurovirulent virus. What is the meaning of that? Neurotropic means a virus that is going to target specifically the brain, spinal cord, or structure of the nervous system. This virus is behaving in a different way. This virus is not neurotropic. This virus is not neurovirulent. In other words, this virus is not producing a major impact in the central nervous system because the virus is invading the central nervous system or spinal cord or optic nerve or brain. This virus doesn't have that property. It may happen rarely, extremely rarely, but those are very different situations and circumstances, particularly because the patient is extremely immunosuppressed and may have neurological consequence after that. However, that is very well known, at least up to now, is that this is not a neurotropic virus. So that means that the neurological consequences of the coronavirus infection at this moment are mostly secondary. So in other words, the damage of the lungs, the damage of the blood vessels, the damage of the heart eventually may produce secondary neurological effects. The complications associated with coronavirus and the brain or spinal cord or the peripheral nervous system are mostly associated with secondary complications. For example, there has been an increase in the effect of strokes. In other words, patients that are susceptible to strokes get coronavirus infections. Those patients actually increase the risk of strokes because the cardiovascular situation, the pulmonary situations. It has been noted, for example, that patients with coronavirus infections develop more brain dysfunction secondary to the lack of oxygenation. So that is mostly a secondary effect, but that doesn't mean that the virus is damaging directly the brain, spinal cord, or peripheral nerves. There are very few case reports, mostly anecdotal reports, of some very rare neurological complications like Guillain-Barré syndrome, that is a neurological disorder in which there is an autoimmune damage of the peripheral nerve that eventually may lead to paralysis. There is only one report up to now of a patient suspected to have that situation. But again, in millions of people that have been exposed to coronavirus already in the world, there are extremely, extremely rare descriptions of neurological complications.
Okay. And then do we know from the experience in China or Italy, are there is there any information about patients infected with coronavirus who have neurological diseases or rare neuroimmune disorders in general? Do we have any experience from them that might indicate how things might go here, or is that stuff we're still learning about?
Yeah, so there are already in the literature coming from China in January through April or early April, as well as from Italy and some European countries and some of the Asian countries. There have been description of the complications that I mentioned before in the previous questions. And again, the majority of these complications that are neurological complications are derived not by the direct damage by the virus, but rather by complications like strokes or lack of oxygenation in the brain or other type of immunological reactions that eventually produce some secondary effects in the nervous system function. It's very frequent, for example, that elderly patients that are affected by coronavirus develop very high temperatures and develop a very important pulmonary dysfunction that leads to lack of oxygenation of the brain. Those patients actually exhibit a lot of mental status abnormalities. The patients go to coma very quickly because the lack of a good oxygen supply, and in some patients, strokes, or the lack of blood supply to the brain because damage of blood vessels.
Okay. And then we did have some questions, that people were worried about potentially being denied care because of their disability or their kind of pre-existing diagnosis. Is there any, talk about that potentially happening, if ICUs get overstretched or that sort of issue?
So the ethical situation at this moment has been discussed at many different levels. And my understanding and our belief as physicians and human beings is we have the social responsibility to take care of everybody, regardless diagnosis or secondary conditions. I don't believe that that is a discussion in our country. I don't believe that's the discussion in any of the hospitals where we take care of patients. I think that we have the social responsibility and medical responsibility as a healthcare providers to provide attention regardless age, secondary problems, race, and other situations, even immigration status, if you like to go to the social side of many areas in our country. So we need to take responsibility as physicians for everybody who is affected by this infectious disorder.
Okay. And then, we've talked a lot about the immune system, but, if someone has one of these disorders and they maybe have weakness or paralysis or kind of residual effects after one of these diagnoses, how would they know if their respiratory function is impaired by their diagnosis?
I mean, the patient is the first one in getting the alarm sign, is the shortness of breath, right? So patients with any rare neuroimmunological disorder that is infected with coronavirus should report his or her situation right away to the care team, primary care physician and neurologist. Any symptom of fever, chills, sore throat in a patient with a rare neuroimmunological disorder immediately trigger or needs to trigger a call to the care team. And it's extremely important that patients understand that any sign of all of these infectious symptoms associated with shortness of breath need to prompt urgent care. So in other words, any sign of shortness of breath, that means that there is some respiratory difficulties, need to take seriously. Patients and families need to take serious care of that situation and notify the primary care provider and neurologist about that situation.
Okay, great. Thank you. Is there anything else that you think we should?
I think that the most important aspect of this difficult situation in the world for patients with neurological disorders and rare neuroimmunological disorders and families is to be alert. I think that following all recommendations that have been explained, following recommendations of isolations, and families need to take extreme care when they have some member of the household affected by rare neuroimmunological disorders, because any misstep, any potential exposure to those patients with rare neuroimmunological disorders may have difficult consequences. There has been a lot of talk about how to prevent, how to be proactive in the prevention of this. And unfortunately, the only thing that we know is just the public health measures like isolation and extreme care to avoid contamination are the only ways to minimize that potential infection. There has been a lot of talk about medications that may be prophylactic, medications that may avoid potential infections, but the reality is there is no proof that those medications are really helpful. There is no proof at all that you can take tons of vitamins, tons of Plaquenil or hydroxychloroquine to prevent this disease. Unfortunately, the answer is at this moment, there is no proof that these approaches are going to work. And the only thing that is important at this moment is to follow the precautions, the isolation, the quarantine recommendations, and the extreme care to protect family members that are exposed to higher risk because they have rare neuroimmunological disorders.
Okay, great. Thank you.
Thank you for the invitation for this podcast, and I hope that everybody stays safe and follow all the recommendations provided by the public health measures. Thank you.
Thank you.